Welcome viewers to my Technology Applications for Health and Human Services video resource project. My name is Marquita Jones and the topic of my presentation is Glidescope Intubation Procedure Education. Throughout my video, I will discuss what a Glidescope is, when it is used, a couple techniques that are used with the Glidescope, as well as advantages, disadvantages, and tips and troubleshooting techniques. Hopefully after watching the video, you will have a better understanding of how a Glidescope is used and maybe even consider using the Glidescope as first-hand intubation versus direct visualization in the near future. What is a Glidescope? The Glidescope is a video laryngoscope that has a 60-degree angle blade with a built-in high-resolution camera and a light source assembled beside it. The image is then transmitted onto a mobile bedside monitor. This procedure has been widely used in medicine for well over a decade. The Glidescope was designed to provide an improved view of the glottis during difficult intubations without alignment of the oral, pharyngeal, and tracheal axes, and it is able to, what they call, look around the corner to facilitate the intubation. Okay, so here I have pictured two different styles of Glidescopes that are used within the facility that I work, which is St. Joseph Health Center of Warren, Ohio. On the left is the Glidescope that I call on wheels. This particular device is normally found in the ER, OR, as well as the intensive care unit setting for emergent situations. It also has the capability of taking and saving pictures of the airway anatomy. The device on the right is what we call our portable Glidescope device, which we use and carry to emergent situations on the floors such as code blues or rapid responses, because once you arrive, you never know what you're going to walk into, so it's always better to be safe and prepared. When is the Glidescope used? As previously mentioned, it is used in emergent situations, difficult intubations, as well as for patients with trauma and cervical spine precautions to facilitate teaching. For example, BLS, ACLS, or even yearly competencies. Also, it is used based off of personal preference. Not everyone prefers to use the Glidescope. Some technicians prefer to use the direct visualization technique with the laryngoscope and blade. The standard technique and alternative technique are the two Glidescope intubation techniques that are used. The standard technique of the Glidescope intubation involves a midline laryngoscopy followed by the insertion of a styleted endotracheal tube, or ETT, once an adequate view of the vocal cords has been achieved. The ETT insertion process requires the operator to look away from the monitor during the laryngoscopy while maintaining the blade position in order to insert it into its initial position. The alternative Glidescope intubation technique has been described for cases in which there is limited mouth opening, a big tongue, or other anatomical impediments. In these cases, the ETT is inserted under direct vision as a fish hook at the side of the mouth before the Glidescope blade is introduced into the oral pharynx. There are several advantages to the alternative technique. The first advantage is that the technique of the ETT insertion would minimize the laryngoscopy time, as a part of it is performed before the blade is introduced and the stimulating effect occurs. This technique thus has the potential of reducing the sympathetic response as well, minimizing the oral pharyngeal laryngeal stimulation time would theoretically attenuate the hemodynamic response. There are several advantages of using the Glidescope. Quicker intubation times, which helps to decrease the interruption of oxygen to the patient, to improve the view of the glottic opening, which is good for decreasing the time to decipher through the airway to find the vocal cords. It's a safe choice for a difficult airway and, as previously mentioned, great for teaching. The disadvantages of using the Glidescope are as follows. Difficulty in passing the ETT despite improved glottic visualization. Variable learning curve, meaning the potential weakening in development or maintenance of direct laryngoscopy skills, especially for those that are non-experts of airway management. So even though you use the Glidescope, you still have to keep up on those skills of using the direct laryngoscopy procedure. The possible increased intubation time, two-dimensional view with loss of depth perception, obscured view where you can have some type of fogging and secretions on the camera lens, again increasing intubation time because of having to remove the blade and clean the camera lens. It could be more complicated for some, and the Glidescope can also be expensive, so every facility may not be able to afford the Glidescope. Here are some tips and troubleshooting techniques to hopefully help you with your Glidescope intubation procedures. Remember, practice makes perfect, meaning use the Glidescope for your easy and routine cases until you're very comfortable with it. That way, when you are in situations where you have a difficult airway, you will already be familiar with the mechanics of the device. Also, if you experience some difficulty in inserting your tube, shift to the left. I know it says you're supposed to stay midline, but you know, it's okay to shift to the left if you're having trouble getting the tube in the mouth. Also, to gain greater maneuverability, you want to hold your tube closer to the connector. Also, withdraw the stylet 3 to 5 centimeters if you encounter difficulty passing the ETT through the vocal cords. This can be done by the technician using his or her thumb, pushing up on the stylet 3 to 5 centimeters. Or if they're having trouble, their helpmate can help them as well as pulling it back a little bit. But you want to be careful because you don't want to pull it all the way out, and you don't want to pull it too hard. Sometimes when you have the hyperangulation of the Glidescope blade and the stylet, it changes the shape of the ET tube distally, and it interferes with the passing of the endotracheal tube through the vocal cords. Once you do get the endotracheal tube through the vocal cords, the stylet can be removed by pulling it out and down toward the patient's chest and feet, following the shape of the stylet, allowing gentle atraumatic intubation, meaning don't pull it too hard. I've experienced this. I've actually seen this firsthand where someone was actually assisting me in an intubation and they pulled the stylet too hard, and guess what happened? The patient was extubated. Now you have an increase in your intubation time because you have to re-intubate the patient. Okay, so here's a picture that I included on the proper versus improper way of Glidescope blade insertion. Oftentimes when intubating, we have the best view, but it is not good enough to pass the tube through the vocal cords. Chances are you're probably too close, so just try backing up a little bit. A lot of times when you insert the blade, you insert it too deeply into the pharynx and it kind of blocks the view. So in this picture, it kind of shows you have a view of the vocal cords but not a full view. So what you want to do is you want to just back the scope up 1 to 2 centimeters to resolve that issue. This concludes my presentation on Glidescope intubation procedure education. Thanks so much for watching. On this slide, I provided a link to the video for Glidescope video laryngoscopy procedure. I hope you could take the time to watch this video as it is very useful and demonstrates how to properly use the Glidescope. And again, thanks so much for taking the time to watch my video presentation.